Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1. This is a Benchmark Education Solutions sample test paper. Extract 1, questions 1 to 12. You hear a GP talking to a patient about an ongoing problem. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mr. Edwards. How are things going today?
Well, not so great, but please do call me Jake.
OK, Jake. So, I see here that you made an appointment because of general malaise and lack of appetite?
Yes, I've been feeling off for about a week. I vomited on one occasion and I've been feeling a bit feverish.
OK. Do you remember seeing any blood in the vomit?
No, not that I can recall.
Have you been experiencing any other symptoms over the past couple of weeks?
Yes, I have. For about 2 weeks, I have had these aching pains in my knees, elbows and wrists.
I see. Your joints don't look swollen at all. OK, any changes in other areas, such as in urine output? What about bowel movements?
No changes there.
So, I want to do a bit of medical history and your overall health. Have you had any infections over the last several years?
Yes, about 5 years ago, I had glandular fever.
OK, and your overall health? Are you a smoker or drinker?
Yes, I definitely am. I smoke about a pack of cigarettes per day, so about 25 or so, and I drink 4 to 5 beers a day, sometimes more on the weekends.
Yes, that qualifies as being a very heavy smoker and drinker.
Yes, I know. I'm also a recreational drug user, marijuana and sometimes ecstasy, that type of thing. But not too often. I mean, I am usually up for whatever drug is being handed out in the club.
Any intravenous drug use?
Oh no, nothing like that. I can't stand the sight of needles.
Well, I see that your temperature is a bit high at 38.6, and you appear to be a little jaundiced.
Do you mean a bit yellow?
Yes, that is what I mean. It often indicates a problem with liver function. Your physical examination showed you to be a little tender in the right upper quadrant of the abdomen. I'm going to need to order some blood investigations. We need to check for liver function and infection in general. The diagnosis I'm looking to confirm is acute viral hepatitis.
I have some friends who have had that. Aren't there different types of hepatitis?
Yes, there are. There are hepatitis A, B or C. The cause of hepatitis A is often eating or drinking something contaminated. You haven't travelled outside of Western Europe recently, have you?
Definitely not. I'm currently unemployed, so no travelling for me. I think the last time I left the country was 4 or 5 years ago.
OK, well, certain behaviours such as homosexuality and intravenous drug use are risk factors for hepatitis B and C. With hepatitis B, there are often joint symptoms, so that is the most likely diagnosis.
So what would treatment look like? I mean, is this something that would affect me the rest of my life?
Well, that depends on the investigations. In the meantime, you should avoid alcohol and drugs as they can further have a negative effect on liver function. I want to set you up with an appointment with a counsellor to talk about your alcohol and drug use. How does that sound?
I don't know.
This is a Benchmark Education Solutions sample test paper. Extract 2, questions 13 to 24. You hear a doctor in an emergency department talking with a patient presenting with back pain. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Chelsea. My name is Dr. Rogan. I see you were admitted to the emergency department for back pain.
Yes, well, not exactly. I have pain across my back. It's not my spine or anything like that that hurts.
Okay, I see. And how long has this pain been going on?
I've been feeling unwell for the past 2 days. It began with a fever and an ache in my back developed. Over the past day, the pain has gotten more and more severe.
Any other related symptoms?
Yes, I think. I vomited twice in the last, 6 hours or so.
Let's see. You look a bit flushed, and you do indeed have a fever. Your temperature is 39.5 degrees Celsius. I can see that your abdomen is a bit tender, most markedly in your loins. I'm going to send off for some investigations.
What are you looking for exactly? Do I have an infection or something like that?
Yes, you likely do have an infection, as indicated by your high fever. Your symptoms point to acute pyelonephritis. It is a sudden infection of the kidneys which occurs because of bacteria travelling up the urinary tract. It is far more common in women than in men.
I don't know if it is related, but I was diagnosed with cystitis. When was it? It was around the time I had that bad cold. It was a couple of months ago. It cleared up pretty quickly. I think I remember my GP saying it was caused by a urinary tract infection.
Cystitis is an infection of the lower urinary tract, but it is likely related. Many patients diagnosed with acute pyelonephritis have a history of cystitis within the previous 6 months. It is good that you came into the A&E because acute pyelonephritis is much more serious than cystitis.
What do you mean, severe?
Well, it can be life-threatening and does cause damage to the kidneys. We need to act fast to avoid permanent damage to them.
Oh my. So what happens next? Am I going to be admitted to the hospital, or do I go home and see what the results of the investigations are?
Well, we are going to admit you to the hospital. Blood and urine cultures will be taken, and we will start you on an intravenous fluids and antibiotics until the organism causing your problems is identified. We need to know which organism in order to know which antibiotic will be the most effective in treating it. The main cause of acute pyelonephritis is Escherichia coli, but there are some other bacteria such as Proteus, Klebsiella, and Enterobacter. We will also need to do a renal ultrasound.
But why? I mean, if you can get rid of the infection with an antibiotic, why do an ultrasound?
Well, one of the possible causes of acute pyelonephritis is structurally abnormal urinary tract. A renal ultrasound scan can check for any evidence of obstruction.
Okay, I see. So you need to determine what may be causing this infection.
That is exactly right. So now let's get you admitted. We will need to do a bit more paperwork.
Of course you do.
Yes, I know. So now.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a conversation between 2 doctors. Now read the question. This is a Benchmark Education Solutions sample test paper.
So I have a patient whose wife made him come in because she thinks he has Alzheimer's disease. She says he is forgetful and irritable all the time.
Is there a family history of dementia?
Yes, his mother died about 3 years ago from Alzheimer's. But my examination showed no evidence of dementia. In fact, the physical examination was normal.
What other symptoms did he or the wife mention?
She spoke mostly about his forgetfulness, but she did mention something about him drinking more fluid and getting up at night to pass urine. But I found no symptoms of prostatism, and there's no relevant family history there.
It sounds like something is wrong, but the usual problems aren't the cause. What did the...
Question 26. You hear part of a training for ward leaders. Now read the question.
Welcome everyone to this initial training for ward leaders. Today we will go over the role of the ward leader as well as preparing for the post. According to the Royal College of Nursing, the role of the ward nurse in the UK is ideally situated in the hospital system to supervise clinical care, oversee quality and safety standards, coordinate patient care activities at ward level, and promote nursing leadership and mentoring. Without doubt, it is a complex and challenging role with many priorities at individual patient level, team level, and organisational level. An effective ward leader is a clinical expert, a leader and manager of the team, and an educator of many. All of you come to this role as a clinical expert and were selected for your leadership and management skills. So our training is about further developing those skills. So now I'm going to hand things over to an experienced ward leader to talk about the specific leadership and management skills required.
Question 27. You hear a ward briefing on safety.
Hello everyone and good morning. I want to start off our regular ward briefing by focusing on safety. As we all know, safety is a team effort. We know from healthcare as well as from other industries that generally it is a system that is to blame when things go wrong. This means that all of our actions should be done according to proper protocol. For example, medicines must be given on time, and tests, investigations and treatments should be appropriate for a patient's condition, with procedures performed correctly and in a timely and effective way. When we start to change the system or the way that we carry out procedures, we are much more likely to make mistakes. This is also why we have a reporting system, so that you can report incidents. Our reporting system allows me to review incidents and make informed decisions to identify areas for improvement for our team. So now...
Question 28. You hear part of a conversation between 2 doctors in the A&E. Now read the question.
How's your day been?
It has been exhausting. I mean, the A&E is never easy, but lately I've been particularly hectic the last couple of months.
I don't know if I would say hectic, maybe backed up. I mean, we have had a lot of issues with the A&E being full because we just cannot get patients admitted in a timely manner. I mean, the other day I had a patient down here in the A&E waiting over 20 hours for an available psychiatric bed.
Yeah, behavioural health patients typically wait quite a while, which of course is very stressful for them. It seems that the system just cannot keep up with the demand for psychiatric beds and mental health treatment in general.
You could say that again. So, enough of the negative talk. Have you heard about...
Question 29. You hear part of a conversation between a GP and a physiotherapist. Now read the question.
Hello, John. I'm just calling to follow up on my patient, Mr. Sanders. I know he had an appointment with you and I'm going to be seeing him tomorrow.
Oh, hello, Dr. Zander. Yes, I saw your patient for his heel pain. He has plantar fasciitis, but I'm still looking into the exact cause of his pain. I ordered an X-ray to make sure a stress fracture or bone spur aren't present.
Any recommendations for the patient that I can follow up on?
Yes, I showed him a series of exercises to stretch the plantar fascia and Achilles tendon, as well as to strengthen the lower leg muscles. It would be great if you could stress the importance of doing those exercises regularly.
Will do. Anything else?
Question 30. You hear part of a training for GPs. Now read the question.
So, in today's session, we will start to talk about inflammatory and papulosquamous disorders. Over the next 6 weeks, in the online tutorial sessions, you will learn about the clinical variants of psoriasis and understand the psychosocial aspects of the condition. We will also cover blistering disorders such as pemphigoid and pemphigus vulgaris. Later in this module, we will talk about the skin and systemic disease, including diabetes and Cushing's disease. As with previous modules, you will have weekly readings supplemented and complemented by multimedia resources, and we will have hands-on clinical days at your designated clinical site.
That is the end of Part B. Now we'll look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear part of a lecture about an inner ear condition. You now have 90 seconds to read questions 31 to 36. This is a Benchmark Education Solutions sample test paper.
Welcome everyone to this lecture on Meniere's disease. Today we will focus on an overview of this disease, how it occurs, what it occurs, and how it presents. As this is a very uncomfortable condition for the patient, we should be aware of how the patient is feeling. Also, just so you are aware, in general, Meniere's disease is not common, with only 157 people diagnosed per 100,000 people in the UK. Also, it is important to know that this is a disease most commonly seen in women, ranging in age from 40 to 60. So first we will cover the pathology of the disease, and once we have done that, we will go into clinical features of Meniere's disease, as well as diagnosis. Then we will talk about some variants, such as Meniere's disease versus Meniere's syndrome. Finally, we will go into the treatment of the disease, including acute and chronic attacks. So first, what is Meniere's disease? It is a disorder of the inner ear where the endolymphatic system is distended with endolymph. In previous lectures, we looked at the anatomy of the ear, including the outer and middle ear. Today, we're focusing on the inner ear, which consists of the endolymphatic system because of the fluid it contains, which is called endolymph. Well, what happens in Meniere's disease is the fluid present in the endolymphatic system increases, leading to the distension of the system. So why does the fluid increase? Well, there are different factors, which we will go into detail later on, but commonly different allergies and infections can cause increased secretion and increased production that can cause this painful disease. So, now on to the common symptoms associated with this disease. First up, we have vertigo, which is quite common. It is the sensation of spinning, so a patient feels like the environment is spinning around them. Another symptom is sensorineural hearing loss. We have two types of hearing loss. One is conductive, and it's mainly due to the obstruction of the transfer of the sound waves from the external to the inner ear. It is not associated with Meniere's disease. The main type of sensorineural hearing loss related to Meniere's disease is associated with nerve injury, often seen with abnormalities of the inner ear. Another common symptom is tinnitus, which is when the patient has a ringing sensation in the ear. The ringing sound can cause sleep disturbances in patients. Now, let's look at pathology. As we already mentioned, there is an increase in endolymph. When this happens, it can put pressure on the Reisner's membrane, causing it to be pushed into the scala vestibuli. This causes all sorts of problems, like the symptoms we just talked about. So let's think about the different causes of the increase of endolymph. So the first is defective absorption by the endolymphatic sac, which will lead to raised endolymph pressure, ischemia of the sac, and distension of membranous labyrinth. Then we have vasomotor disturbance, which is sympathetic overactivity resulting in spasm of the internal auditory artery. This can lead to deafness and vertigo. Next, a very, very common cause is allergy, which leads to a production of excess endolymph. With allergies, we have other symptoms also, like sinusitis, a runny nose, and a sore throat. Other less common causes include sodium and water retention, hypothyroidism, and autoimmune and viral etiologies. So, taking what we know about the causes of Meniere's disease into account, we can come up with a list to help us come to a diagnosis. In general, a diagnosis of Meniere's disease requires 2 episodes of vertigo, each lasting 20 minutes or longer, but not longer than 12 hours. Nausea and vomiting during spells of vertigo are quite common. What should not be accompanying the vertigo are neurologic symptoms. In addition, there must be hearing loss that will be verified by a hearing test. Hearing loss tends to be progressive and usually unilateral. Next on our list is tinnitus, also commonly unilateral. Finally, it's important for the doctor to exclude other known causes of these problems before coming to the diagnosis of Meniere's disease. Before we talk about treatment, I want to talk a bit about the variants seen. First, there is the difference between Meniere's disease and Meniere's syndrome. So both result from increased pressure within the endolymphatic system, but the first is idiopathic in nature, while the second can occur secondary to various processes interfering with the endolymph. So now,
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview about early detection of breast cancer. You now have 90 seconds to read questions 37 to 42.
So today, I am delighted to be able to interview one of the researchers who is on the cusp of making a medical breakthrough that will positively affect all women around the world. Wow, that is amazing to consider, isn't it? I mean, all women around the world could be positively impacted by this research. So, Dr. Harris, welcome. It is an honour to have you here.
thank you for the invitation. It is certainly a privilege to be here to share with all of your listeners the research that I've been working on for much of my professional life.
So most of you have probably seen the headline saying that a simple blood test for early detection of breast cancer is in development. So today, that is exactly what we are going to learn more about with Dr. Harris here. So Dr. Harris, how is this even possible? A simple blood test?
Yes, a simple blood test. So cancer cells produce proteins called antigens. These antigens trigger the body to make antibodies against them, autoantibodies. So we realised that these tumour-associated antigens are good indicators of cancer, and so we started to work on developing panels of tumour-associated antigens that are already known to be associated with breast cancer.
Yes, this is the pilot study that your research did at the University of Nottingham, correct?
Correct. We took blood samples from 90 breast cancer patients at the time they were diagnosed with breast cancer and matched them with samples taken from 90 patients without breast cancer. We used screening technology that allowed us to screen the blood samples rapidly for the presence of antibodies against 40 tumour-associated antigens associated with breast cancer, as well as against 27 tumour-associated antigens not linked with the disease.
So what was the result of that pilot study?
Well, the results of the study showed that breast cancer does induce autoantibodies against panels of specific tumour-associated antigens. We were indeed able to detect cancer with reasonable accuracy by identifying these autoantibodies in the blood.
What do you mean when you say reasonable accuracy?
Well, it is important to mention that we identified 3 panels of tumour-associated antigens to test for antibodies. We found that the accuracy of the test improved in the panels that contained more antibodies. For example, the panel of 5 tumour-associated antigens correctly detected breast cancer in 29% of the samples from cancer patients and currently identified 84% of the control samples being cancer-free. But the panel of 7 tumour-associated antigens correctly identified cancer in 35% of cancer samples and no cancer in 79% of control samples. Finally, the panel of 9 antigens correctly identified cancer in 37% of cancer samples and no cancer in 79% of the controls.
Interesting. There was a much bigger jump in accuracy between the panels with 5 and 7 tumour-associated antigens than between 7 and 9.
Yes, that is true. We're working to develop and further validate this test. We are currently working on testing the 9 tumour-associated antigen panel with samples from 800 patients.
That is definitely needed. But these results are so encouraging. I mean, they mean that there is a possibility of detecting a signal of early breast cancer.
Yes, and the fact that it is with a blood test is particularly exciting because it means it would be cost-effective. It wouldn't be something that could only be done in wealthy countries. Low and middle-income countries could use it as well.
So your research is focused on breast cancer. Are you aware of similar research with other types of cancer?
Yes, there is a similar test being developed for lung cancer. They are currently doing a large-scale trial involving 12,000 people at high risk of developing lung cancer because they smoke. Also, my research group is in the early stages of working on similar tests for pancreatic, colorectal and liver cancers. These types of cancer, along with lung and breast cancer, account for around 70% of all cancers.
That is simply amazing, but it does make me wonder how patients will react to this type of news. Early detection and diagnosis definitely result in better outcomes for patients. But what would it be like to receive the news that your blood work is showing you will develop breast cancer, but we don't know when? That is difficult.
Yes, that is certainly an issue doctors will have to deal with as these types of tools become available.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.